So because of the known adverse prognosis of these patients with FLT3 mutations and the fact that these are kinases, there was a strong interest in developing FLT3 inhibitors for many years. And many of them have been developed, and some of them have already been approved and are available in the clinic. And they can grossly be classified into two categories: what's called the type 1 inhibitors, which are inhibitors that work both in the active and the inactive conformation of the kinase, and then the type 2 inhibitors that only work in the inactive conformation of the kinase. So that includes sorafenib and quizartinib, whereas the type 1 include midostaurin, gilteritinib, and a few others. The distinction between the type 1 and the type 2 is that the type 1 inhibitors that, as I mentioned, work against both the active and the inactive conformation, they inhibit both the FLT3-ITD and the FLT3 kinase domain mutations, whereas the type 2 inhibitors, I remind you, sorafenib and quizartinib, only work against the ITD mutation. So that is an important thing to keep in mind. And we're going to be talking about what the clinical implications of these has been throughout the different studies.